Good afternoon. I wanted to first thank everyone for joining our first cervical cancer-free webinar, Strategies to Increase HPV Vaccination Among Your Patients in the United States. I have the honor to present our speaker, Dr. Alex Kassler, who will be presenting on provider interventions to increase HPV vaccination in the United States, a successful quality improvement example. Dr. Kassler is a pediatrician who's been in practice at the Physician Associates in Central Florida for 20 years. She's an associate clinical professor of pediatrics at the University of Central Florida College of Medicine. And she will be presenting today on some very exciting example of intervention that increased HPV vaccination within her pediatric clinic. So thank you very much, Dr. Kassler, again for joining us. And just in terms of a few logistical issues, can I ask all that participants to please mute their phones in order to avoid background noise? And we might remind as we move forward that please mute all of the phones. And I also wanted to remind us, for those, you can see on the right-hand top corner of the screen, a question and answers box. So please feel free to ask literally many questions. We will try to address all of them in the question and answer session at the end. So please feel free to ask questions as Dr. Kassler goes along. I wanted to also make the announcement that this webinar, for those of you or friends of yours who could not join today, will be available and archived on our Cervical Cancer Coalition website, cancerfreecoalition.org. And we'll send a follow-up email when the archive webcast is available. So thank you again, Dr. Kassler. And without further ado, I will now pass the baton to you to start our presentation.
Great, thank you very much. I hope everyone can hear me.
I assume I'll get feedback if that's not the case. It's a big honor for me to be asked to talk to you about the project that we did within our group. I'm actually very proud of the work that we've done, and I'm hoping sincerely that something that you take away from this talk today will inspire you to kick some butt in terms of HPV immunization rates, if you'll pardon my speech. I am a practicing pediatrician. I work half-time taking care of patients in my office, and then the other half-time I work on clinical quality projects at Orlando Health, which is a large hospital system in the Orlando area. And I also teach for various schools, as you can see on the screen. So I really enjoy kind of the cross between a little bit of academics and some clinical pediatrics. I hope I have control over the slides. I'm clicking and, oh, there we go. Whoops, it was just a little slow, sorry. I should disclose to you that I do speak and consult on vaccines for both Merck and Sanofi. This is a passion of mine, and they have given me the opportunity to share the excitement about immunization, if you will. So I feel very grateful to them to be able to express my, again, excitement about vaccines and preventative medicine. My goals for you today really will be that by the time you hear what our group did, and I'll tell you about our group and what we did, that you're going to want to turn around, and no matter what kind of a practice you're in or group you work with or group of people with whom you have contact, that you'll be really excited. I mean, to me, this is very exciting, so I hope it's exciting to you, but I'm really excited to go back and look at how you're doing with respect to HPV immunization, or how the department that you work with or the organization that you work with and the people that you come in contact with are doing with HPV vaccinations. I'll come back to this time and time again, but I think that we all think that we're doing better than we are until we get the opportunity to see how we're doing. I also hope that you'll be motivated to implement change within your organization, and that something that I say today will leave you feeling knowledgeable enough to move in an effective direction in terms of establishing some sustainable process improvement in your organization. I should tell you a little bit about our practice. We are a large multi-specialty healthcare group. In fact, we are the largest multi-specialty healthcare group in Central Florida. We are comprised of over 100 physicians, 22 of whom are pediatricians, 2 pediatric nurse practitioners. We have about 80 staff working with us, spread throughout the Central Florida area in 11 offices. So we are not centralized. We are very diverse. We service a group of about 57,000 pediatric patients, with a little less than half of those being in the preteen and the preteen years. Over the last several years, we have gone through the process of certification as a level 3 patient-centered medical home through the NCQA, which has been quite a chore and quite a task, but we're very proud of that. And every office and all of our specialties are certified as such. But as a really, really large group, we represent varied populations throughout the city. We represent every demographic that you could come into contact with and every payer. We have practices that are essentially 100% Medicaid. We have practices that are exactly at the opposite end of the spectrum. And so the challenges that we each face on a day-to-day basis in our practice vary greatly. And our processes had to account for all of that. So hopefully, whatever your practice style or the groups that you work with, you'll see something here that you can take away and apply. So the problem that we face, I think, is not rocket science, and it's familiar to all of you. But the reason that I bring this up and put this data up here is not because I don't think you don't know it, because I actually think that if you're logged into this webinar, you know this stuff. But the thing is, if we don't own this information on a day-to-day basis in our practice, I think we lose sight of why we have to emphasize HPV immunization. And if you haven't gathered yet, I am the immunization champion for our group. And you'll see, I'll mention later on, it's really key, I think, that for any project like this, there be a champion. Someone who owns the data, someone who's passionate about the data, and someone who continues to remind people about the data, because we have not done well as a country in terms of HPV immunization. Between 2011 and last year, yeah, rates increased initially, but once we said, oh, we should be immunizing, we kind of forgot that we needed to keep going. And so from 2012 through 14, national rates have hardly budged, where if we had done a really good job of at least immunizing with HPV when we had patients in the office who were already getting other shots, we could be at over 90% immunization rates for that vaccine. So if we went ahead and did that, and I think we need to own this, we would be preventing significant amounts of cancer. The data suggests that if we hit Healthy People 2020 goals of 80%, we will prevent about 53,000 cases of cervical cancer in the lifetime of that cohort of our patients who are now under 12 years. So the reason for being pushy and being excited is looking at our own patients and looking at the number of patients that we take care of, and looking at how many cancers we could be preventing in our own population. So I'll talk a little bit about our project by telling you that the first thing that we did, we've been involved in many different quality projects in our group. So my partners were not surprised when I came to them with another project and said, hey, I think that we need to work on our HPV rates. The CDC has spoken about this as being a problem, and we have a bigger problem than the CDC does. And this is the slide that I showed my partners in 2013, fall of 2013. Remember that the National Immunization Survey data is a year behind. So when you look at the purple row of National Immunization Survey data for HPV recipients, that is from 2012. And if you look just above that at the tan row, that's our data. So you can see that we were running half of national rates as a group. And again, at that time, our population in our age group that we were looking at compared comparing to the national immunization rates, which is age 13 through 17, was almost 16,000 patients. And even though the CDC was saying, you guys, the nation is not doing so well, we looked and said, well, we're not even coming close. The lavender rate at the bottom is actually our best provider and the immunization champion in the group. So it was clear to our group that the rates could be achieved. You could do well, but my partners were blown away. I mean, the biggest thing that they came away with was, wait a minute, we're great doctors. We think we're doing a great job. How could our rates be this poor? And something must be wrong. I would say that that was the beginning of an interest in quality improvement. So we sat and talked about different ways to improve quality. And any of you who have ever worked on any kind of a quality improvement project is probably familiar with the tried and true, validated PDSA cycle: plan, do, study, act, where you take a small, you identify a problem. This is what we want to fix. You say, okay, let's try this small increment of change and let's test it and see how it goes and see if it works. And we've used PDSAs within our organization, within the larger hospital system for years. But we looked at our HPV rates and said, we don't have time, we don't have resources to work that small. We need to do something bigger. We need to really, really make a mark, because we've got this large population of kids who are going to grow up and graduate from our practices without a vaccine if we don't change what we're doing and if we don't change it now. So we did what is now called in quality improvement circles strategic parallel processing, which we called shotgun approach. um, and we basically brainstormed all sorts of ideas as to what we could do and how we could do it and what we could try. And I'm going to share a number of the different things that we put into effect to see what would work. But we did have to kind of keep a few things in mind that really do fit the traditional QI methodology, which were, we had to make sure that we kept what we were doing relatively simple, because we already have a huge workload. We're doing the patient-centered medical home. We're on the EMR. But to ask anyone to do more work is really, really challenging. And this needed to be something that would work office to office and would maintain itself over the years. We didn't want to just be a flash in the pan and then have everybody kind of burn out and not follow through. So I want to give you a preview of our results before I start talking about our detailed approach, because the reason that I was blessed enough to be invited to speak here is because we actually did something right. And if you look at this table, you can see, and I'm comparing our rates to National Immunization Survey teen rates, and I'm looking at percentage increases between 2012 and 2014. So I was able to kind of compare apples to apples here. And you'll see that nationally, the increase in males receiving a full series was 104% over that 2-year period. And I think we did significantly better than that. Nationally, the percentage of women receiving a full series showed really small increases, where ours were pretty substantial. And for a single dose, I think we achieved similar improvement rates. And so for our group of anywhere from 16,000 if you're looking at 13 to 17-year-olds, which is what the National Immunization Survey looks at, to 23,000 when we go down to our 11-year-olds. If we can sustain this rate of increase, I think we've got something that works, and so that's why I'm very, very excited to share it. So our approach started, as I showed you with that initial slide, with sharing our rates. And in September of 2013, when we met for our monthly department meeting, that's the slide that my partners saw. You got a screenshot of the slide that made everybody nervous about why we weren't doing as good of a job as we thought we were doing, and talking about what was in our way. I did have each individual physician's rates with me in my notebook at that time, but offered to share those with each physician privately so that people wouldn't be shocked at a public revelation of data. Now, my partners are used to revealing data to one another. Our quality projects that we had been working on up until then, including asthma, flu shots, and our patient-centered medical home and meaningful use work, we were already sharing all of our data openly, completely transparently within our department and within our company, so everybody knew how everyone else was doing. And we agreed that after this initial reveal, we would share each doctor's rates month by month at our department meetings, and those rates were published initially monthly, and then once we sort of got underway, we started publishing those on a quarterly basis. So first thing was knowing our rates and honestly becoming transparent to each other. We recognize that we are each an integral part of the group and we're responsible to each other. We then had to set some goals, and frankly, for 2013, since we revealed our rates in September, we just wanted to do better. And we sat and said, gosh, can we set ourselves a goal in a few months? No, we just want to see that we can make a change and that we can improve in what we're doing. But then we sort of brainstormed, and a few of us who were most interested decided to set a relatively high bar. And I think that this was critical for our success, and I can talk more to what my partners thought in terms of critical parts of our project. But if you don't have a goal and you just sort of go into it saying our rates are not so great, then I think you may not shoot as high as you could. So we decided that we wanted to take national immunization survey rates for girls, which of course are much higher than those for boys. And we wanted to achieve those rates for our entire population, 11 and up, not just the 13 to 17. So we really set ourselves a high bar based upon the fact that we're supposed to be immunizing at 11 to 12. And so we want to see our rates above national immunization teen rates for our 11 to 12s. We should be done by 13. So for 2015, we wanted to meet national rates. For 2017, we have decided as a group that we want to meet Healthy People 2020 goals, which is 80% series completion. And for Healthy People 2020, the rates are supposed to be for 13 to 15. We would like to see that by age 13 in our practice. So again, I think goal setting is critical in terms of knowing where you're headed and knowing how you're doing, and motivating people to make a change. We then established a set of interventions, and this is just a summary slide to show you what those are, and I'm going to get into detail on a number of them because I hope that some of them will be interesting to you. Our data verification and cleanup, I should let you know that we are, just like every other medical group, we're on the EMR for X number of years, and we did want to go ahead and clean up our panel, and patients that we hadn't seen for 7 years probably aren't ours. I will say that when we cleaned up our panel, our rates improved a little bit, but our overall N did not decrease significantly, and so we felt that that was not a statistically significant effect on our initial data over the first month of cleanup. We then did educational programs, incentives, and changed some of our office flow. We also utilized some tools that were provided by manufacturers and some of our EMR tools, which I'll go into in detail. The physician education program was probably the most valuable thing that we did, which is really interesting to me and was very interesting to my partners because we're supposed to know this stuff. But it became clear to us, or to me, relatively early on in our discussions when people grumbled and groaned about having HPV be a priority, that everybody needed a little bit of re-education. And what we did was we had a dinner program. We brought in a nationally recognized speaker who is very, very adept at scripting and wording and educating on immunization in general and on HPV in particular. And he came and spent an evening with us over dinner. My partners almost all came, and a few key points came out of this. First of all, it became very evident in talking with my partners that they were really concerned about multiple competing priorities. Oops, sorry about that. We, are all involved in getting better and better at using our EMR. We're all involved in multiple requirements for patient-centered medical home and quality projects, and so whatever we were going to do was going to have to be relatively simple so that it could rise to the top of all these competing priorities. We also found that physicians, as smart as we are and as much as we know, were still relatively unaware of the ubiquitous nature of HPV disease and what it causes, which we needed a reminder. The biggest thing was physician discomfort. Ugh, that's so uncomfortable to talk about. They didn't talk about it as a cancer vaccine. They talked about it as an STI. They acknowledged that their patients weren't sexually active, so they don't really need it. And then the biggest myth that we came upon was it's the parents, it's not me. I'm talking about it, it's the parents. They've read the wrong thing, they don't understand, they don't want to do it. And the fact is they needed the words to use to get through to parents. And our speaker gave us words, perfect words to use. It's a bonus. This is a cancer vaccine. You don't put your seatbelt on when you pull onto the freeway. You put your seatbelt on when you're pulling out of the driveway. We could go through scripting for half an hour, but better words to use. And then the big thing was the unawareness of the routine 11 to 12-year-old recommendation and the fact that if you actually recommend this vaccine at 11 to 12, it's easier because you don't have to talk about sex. You can talk about skin to skin and the fact that almost all of us have had HPV, that it usually clears, but unfortunately some people go on to develop cancer. We developed a physician incentive program, which was really interesting. It became part of our quality bonus structure, but to be honest with you, the biggest incentive was seeing each other's rates. Physicians are naturally competitive, and it worked great. And then for about the first 5 department meetings, when we presented our data on a monthly basis, I brought in bottles of wine for the top 3 improvers. And you'd be amazed at how excited it was for people when they were recognized for making an effort and making a difference. We had staff education programs in each of our office, and again, we have about 80 staff. One lunch. They were run by one of the salespeople from a manufacturer, as well as physicians and office managers within the office. The program was developed to be consistent from office to office to teach exactly what the physicians learned, what HPV is, why we vaccinate, what it's for. And it was not surprising that the key points that we came away from staff education were that they were concerned about multiple competing priorities. They were unaware of HPV disease and the recommendations for immunization at 11 to 12, and they were uncomfortable talking about it. But the biggest thing that we came away with was the fact that our staff was a vastly untapped resource. These are people who were on fire once they were given permission to educate parents, reach out to parents, and work with parents before the physician even walked into the room, so that half the time our patients were primed for immunization by the time they were roomed. Being given permission to do something bigger than just check people in, check their vitals, being given permission to reach out, educate, and bring patients along in their medical process was a big, big, big untapped resource for us. And I would really inspire you to pursue that in your organizations. It's huge. As part of our patient-centered medical home process, one of the things that we do is every morning we do written pre-visit planning or a huddle. And different offices do it in different ways, and I'm sure all of you are familiar with the huddle if you work in an office practice. What we did was simply add, and this is an example of my daily pre-visit planning, each patient who's going to come in has various things that we're going to work on, whether it's depression screening, smoking, nutrition and activity counseling, and we added HPV immunization to our standard pre-visit planning, which means that the staff that's rooming patients is aware before they even check the patient in of what vaccines they're going to be getting or what vaccines I'm going to be asking them to get. And we do this again through our entire system. So my MA, when she rooms a patient, says, oh, by the way, you're going to be asked to do the following vaccines today. Here are the vaccine information sheets. Please read them over. Can I answer any questions for you? And many, many times, parents will say, oh, that one, I'm not comfortable with that. But our staff is now armed with, well, you know, it's a really important cancer vaccine. We really want to do that today. I've immunized my children. Dr. Kassler's children are immunized. They don't need to get into the data and the science, but the energy and the passion comes through. And many, many, many times, parents are ready to immunize with whatever vaccines are on the docket before I've even walked in the room. I did mention that we went electronic, and as many of you have experienced, going onto an EMR is not a piece of cake, but again, having a champion in the group who's willing to take a little time to build order sets makes things more convenient. And we do have an order set built, and you can see these are problem-based orders, and you can see the diagnosis in the upper left in the circle as well child visit. And when we click on those problem-based orders, every single vaccine that we might order comes up with a nice single click to order the vaccine. And by putting them all in one place, it makes it easy for the physician to say, oh, by the way, as we're chatting, I'm clicking. The vaccines that we'd like to do today for your 12-year-old are your second hepatitis A, click, your HPV, click, your meningitis, click. And oh, by the way, if that's enough shots for you today, that's okay because we can do your Tdap when you come back for your next HPV, click. So I would encourage you, again, if we're looking at ways of improving, it's got to be easy. It's got to be something that doesn't interfere with workflow, that actually improves workflow. And if you're on an electronic record, that's the easiest thing to add into your order sets. When we order our first HPV, we always order the second and third. And this was one of the most highly rated interventions as well by my partners. I can't tell you how well this went over. And I'm going to actually jump ahead and then come back. But I was talking about electronic order sets. Again, in our well child visit order set, we had follow-up orders built in for the second and third dose. Come back for dose 2 in 2 months, come back for dose 3 in 6 months. So click, 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 done. What that meant is that those electronic orders printed out on patients' clinical summaries at the end of their visit. So, reminder, come back in 2 months for your second dose. Reminder, come back in 6 months for your third dose. Those generated reminder phone calls because every single appointment that's scheduled generates a reminder phone call. And those appointments were scheduled before the patients left the office. This was a big change for us in terms of our flow because we had to keep our schedule open. You know, doctors, oh, I'm going on vacation next month. Cancel my schedule. You know, don't open my schedule. We committed as a group to keeping our schedules open 6 months in advance. That meant planning ahead, at least for our staff, and making sure that we were covered and that there was going to be a physician in the office so that we could schedule our vaccines all the way out. Again, what that did was printed out an appointment on the clinical summary. Generates a reminder phone call though for those appointments. If someone no-shows or cancels, we know. My secretary knows. If someone no-shows, hi, this is Lydia. Just calling because we missed you today for your HPV vaccine. Can we please reschedule that? Now, if a parent calls to cancel an appointment, Lydia says, I totally get it. Thanks so much for calling, but this is really important. Can I reschedule that for you? And if the parent says, well, I'm driving to track practice right now, that's okay, no problem. I'm going to give myself a message to call you next week. Can I call you Monday morning so we can reschedule this? This is something that allows us never to let doses slip through the cracks. So part of this is keeping the schedule open. Part of it is catching people before they leave to schedule those visits. And part of it is my secretary owns the fact that we're preventing cancer. So she never, and this is our entire practice, I'm saying my secretary, I mean all of our secretaries, never says, oh, you need to cancel that, no problem, call us when you want to reschedule, click. That doesn't happen in our practice. Oh, you need to reschedule? Fine, let's do that now, so that everybody owns the fact that we are preventing cancer. I mentioned the clinical summary, and again, this is the power of the electronic medical record. It is a nuisance until you learn to use it, but when a patient receives a clinical summary, they will get all of their diagnoses, all of their meds, vaccines given, and again, follow-up appointments. That can be emailed to them or it can be printed out, and it's a reminder to them that this is something that we see that's very, very important. We do utilize a registry in our practice. Um, we utilize FITEL, which is a registry that lives on top of our EMR, and it mines our appointments. So patients who have appointments for physicians and nurse appointments, and I will say that FITEL was turned on originally to remind for physician appointments. When we started doing our HPV initiative, we realized that it wasn't turned on to remind people about nurse visits for shots. It was the easiest thing to turn that on so that patients get a reminder call when they've scheduled an appointment to come in to see our nurse for a vaccine. That was such a simple thing to do. And now when patients get a phone call, they have the opportunity to confirm that appointment with the click of a key on their phone. They have the opportunity to cancel or reschedule, but in the morning my secretary sees every appointment that's been canceled or rescheduled, and to her, a nurse appointment for an HPV shot is just as important as a well visit. So again, those get tracked and followed up so they don't slip through the cracks. And I think that our parents now realize that these are so important that we're paying attention to them. We're not nagging, but we're reminding them for a vaccine just as much as we remind them for a well visit. So they think it's important too, and they come. We did use some reminder tools that I want to point out to you, not because these particular ones are going to be exciting to you, but because it's worth looking at what your manufacturer has to offer you. Um, there are reminder cards. We didn't use those. There are text reminders, which some of our patients chose to use, and they could sign on with the QR code, I think it's called. Sorry, I'm old, so I'm not sure if that's the right name for that. And there are a number of studies out of Utah, New York, and other places showing that text reminders for teens for HPV vaccines work great. We liked the refrigerator magnets, and this is the old one. I actually couldn't find a picture of the new one online, but they light up when your next dose is due, and they light up when your final dose is due. It's sort of like being at a restaurant and having your table ready, and families really like these. They're a gimmick, but it reminds them of the fact that this is important. We'd rather not have you just skip the second dose or forget about it. We really, really want you to come in. So what kind of feedback did we get within our group? This has been an ongoing project. We've been at it now for 2 years. The highest rated interventions by far were the education programs. My partners and I all realized that we didn't know as much as we needed to know, and that we didn't have the strategies at hand to present the vaccine in a way that parents would receive it as well as they could. We really appreciated learning scripting. We really appreciated empowering our staff, and our staff appreciated being empowered. One of my next studies, which I'll mention later, is going to be looking at longevity, because we have found that as we've empowered our staff in all of our quality initiatives, from our secretaries to our MAs to our nurses to our office managers, that they enjoy their jobs more because they feel like they bring more to the table. Again, scheduling subsequent doses real time, I think, is a no-brainer. That across the board, all of my partners rated as the second most preferred intervention, secondary to our education programs. And then the manufacturer supplied tools really rated very highly, including also tear sheets, posters for the office, and the CDC has some fabulous educational one-sheets that are available that we use for our patients as well. Reveals that came from feedback from my partners and from staff, I have to tell you, data transparency was something that was initially very uncomfortable, but became a tremendous motivator. And within a very short period of time, my partners were very, very open with the fact that they liked the competition. Physicians are competitive, they liked it, and they really, really bought into the process. The bonus controversy was kind of interesting. Um, Physicians, sadly, I would say, are motivated financially a little bit. And initially, our bonus proposal met with some resistance. If our HPV rates are that low and if parents are so unreceptive, how can we hook money to this? That's not fair. There actually is some data out there. Daniel Pink has a wonderful video on YouTube about money as a motivator that shows that the more cognitive an intervention or the more cognitive effort required, the less money as a motivator. Well, I'll tell you that at this point, I almost feel like it's not the money that matters to my partners, it's the tiers of our bonus structure. And everyone wants to be in the top tier because we're totally transparent to each other. And the little bit of money that's offered is nice. I almost feel like a bottle of wine might be just as nice. But that competitive nature and being in the top tier and seeing how everyone is doing has been a huge motivator for us. So again, I want to show you how we did, and I want to show you over time how we did. Some people like to look at graphs, and some people like to look at tables. So I was asked to show you both. I have a graph coming up, but this is a table of how we did. And if you look at the first row, that's national immunization study data or survey data at the end of 2012 compared to our data mid-2013. And again, that's similar to what I showed you in the first slide, where we were at about 50% of national rates. We were very similar to Florida rates, and we are Central Florida, so I guess Florida was kind of behind, and we were not leading the state of Florida, let's just say. But by the next year, um, by the end of 2013, we had already essentially almost doubled our rates. In some cases with males, we had tripled our rates. And by 2014, and again, remember 2015 was where we wanted to eclipse national immunization rates. We did it by 2014, and I think in a fairly significant way. So if you look at series completions for girls at the end of last year, we were at 43%, where nationally the rates were at 39, 40%. And series completion for males, we had pushed up to almost 30%, where nationally rates were hovering at around 21, 22%. So I think that our intervention has worked quite effectively. I have it broken down in a graph here, and you can actually see on this graph where each of our pieces of our intervention were. Data revealed at our department meeting, the physician education program happening thereafter, staff education programs happening over a couple of months thereafter. And then you can see where our rates really started to increase. And then you'll see that summer physical season happened over that next summer. And we had a lot of series completions where we had series starts. And I'm going to break this down for you and highlight for you. So the top line, of course, is females who had gotten at least one dose. Makes sense. They were at the highest, but you can see where we started out way below, and the little blinking star was the national rate as of the end of 2013 compared to our purple line. And then if you look over to the right, the little blinking star now is where national rates sat at the end of 2014 compared to where we sit. And then if you go down to the red line is actually female completion rates. And again, we started below national rates, and as of the end of 2014, exceeded national rates. The green line is male series starts, and same thing, Look at the little flashing star. We were below national rates and now substantially above national rates. And then same thing for our male series completions, where we were really abysmal when we started out, and I think have done very, very well. Um, so, so I think, again, compared to what happened nationally, where the CDC has been really appealing to people to say, hey, let's get out there, we feel like we've done pretty well. A nice side effect, I will tell you, is that we looked at our other teen vaccine rates, and we've improved in terms of meningococcal rates, and we've improved in terms of Tdap rates as well. I think just general awareness of immunization and the ability to talk about vaccines and the comfort with talking about vaccines openly with our patients has led us to, a script for our 11 to 12-year-olds. Well, we have 3 vaccines to do today. The first vaccine is meningitis. Meningitis is rare, really rare, but it's very, very deadly. And so that's a vaccine that we really want you to get. We really want you to start the HPV vaccine because by the end of that series, we'll be preventing a significant number of cancers. And we'd like you to do your Tdap because we'd rather have you not spreading whooping cough around the middle schools so that we can protect our babies. Do you have any questions about any of those vaccines? And then parents may ask their questions, but because we've presented them as all equal vaccines of equal priority, it sets the stage for parental acceptance. We do have some next steps in our project because, as you can see from our graph, we leveled out a little bit. I will tell you that over the last couple of months we picked up because we had our summer physical season and our data is looking even better. But we've already started our sustainability lectures so that we can review guidelines and goals with our staff. We can educate new staff who've just come on board and kind of revitalize the effort. We want to show people how well they've done. Our sustainability lectures actually include office-specific data so people can know where they started and how they've done, so people can feel really good about their efforts. And we also review with our staff now efficacy data from the package insert so that they can realize that if they're taking care of 3,000 or 5,000 patients within this age group, they're going to be preventing X number of cancers so that they can really personalize their cancer prevention and realize that getting into a little uncomfortable zone, asking people to do a vaccine, might save that particular child's life that they're talking to. Put together surveys so that we can identify best practices, our real high flying offices where physicians are already in the 80% vaccination rate, and we have 3 offices who are already there. What's being said, what's being done that's so excellent so we can carry that over to our other offices. And then we've already had physicians in the department requesting another lecture. We want a refresher. We want a refresher on the words that we use, on the approaches that we take to patients so that we can take our rates from 50, 60% up to that 80% goal. So I haven't talked about every single thing that we did, but I talked about the most highly rated things, and I'm coming to you now with sort of a takeaway to-do list. I would encourage you first and foremost, whether it's within your own group, whether it's groups that you work with, whether it's even a chapter of the American Academy of Pediatrics that you work with, to get down to the nitty-gritty and know your rates, whether that means pulling from a registry and an EMR, whether that means reaching out to your VFC provider, whether that means reaching out to insurers for data, whatever you need to do to know your rates so that then you can set a specific goal. You need a champion. You need somebody who owns either immunization in general or HPV immunization in particular in your group. And I think you need one in your whole organization and at each office level. And that's one thing that we've been working on in our sustainability is developing a champion at each office. Physician and staff education is priceless. And anybody who wants information about how we built those programs, I'm more than happy to have you reach out to me. You can reach me through the Cervical Cancer Free Coalition. I can help you with curricula if you want. Incentives are not a bad idea, although I will say that it doesn't have to be anything fancy. Again, a bottle of wine was a big incentive for my partners. And then the defined process improvement. What are you going to do in your offices? How are these going to be ordered and tracked? Remember that these things need to be simple. They can't add
Well, workload, they need to simplify workload, and they need to
have staff turnover. It needs to be built into your office structure. Finally, I just want you to know that there are some nice checklists that iterate some of the things that I've discussed that have been offered by Merck to various offices, and those are available at the Cervical Cancer Free Coalition website. If you click on the News tab, you'll find links to those 3 checklists, and you can use those within your offices. And that's my summary of our talk, and that's my motivation, my 5 kids, and they're all immunized and have spent time promoting immunization in their own lives at college and high school. And I'd love to hear from you if you have questions.
Great. Thank you so much, Dr. Kassler, for your very innovative and exciting presentation. I think we can also just encourage all of the participants to please add additional Q&A questions in the box on the right. We can also take actual questions right now, given that the line actually is live. So for those of you who want to ask questions, you can unmute your phone now. Is there anyone who would like to ask a question? Otherwise, I do have a series of questions that have been emailed to us in the interim. Is there any questions on the line? Okay, so I think I'm going to go then and refer to some of the questions that were emailed to us. So Alex, you mentioned, I'm quoting, you mentioned that you were the vaccine champion in your pediatric group, and you mentioned also that you wanted to generate, identify champions for other practice groups. And so could you talk to us a little bit more about what you think a vaccine champion means specifically to you? How do you define a champion exactly?
absolutely.
So,
Pediatrics is about preventative medicine. And I think most of us in pediatrics spend most of our time doing health and wellness education, and immunization is a huge part of what we do. And I think that I'm at an advantage because I'm 54 years old, so I've lived, eaten, and breathed the diseases that can be prevented by vaccines. And so whether it's pneumococcal immunization or H flu immunization or meningococcal immunization, I've lived, eaten, and breathed those diseases. And to me, this happens to be my hot button. To some people, the hot button is diet and exercise. To some people, the hot button is behavioral. I think it's a matter of finding someone within your organization who owns the concept of immunization in general to become a vaccine champion. If that's somebody who isn't 54 years old and hasn't lived, eaten, breathed the old diseases, it might be somebody who's young, who's lived, eaten, and breathed someone with an abnormal PAP or someone with cervical cancer. And it, again, does not have to be a physician. It can be a nurse. It can be someone who's been there on the front lines personally, who can be armed with the information of what this vaccine can do to prevent disease and how safe this vaccine is, and therefore how much of a no-brainer it is that this is the kind of thing that we need to be encouraging our parents to do. So it needs to be someone who's willing and able to understand the science. It needs to be someone who's willing and able to push people out of their comfort zones a little bit. And I think the best way to do that is to give people credit. And again, this gets back to empowerment of staff. My nurse is one of the most incredible immunization champions I know. Now, she's mine, so we've got a heavyweight in our office. But we have a woman in our practice now who has taken on some of our vaccine tracking. She's a part-time office manager who got excited about our data. and said, wow, wait a minute, if you've given this many more HPV vaccines and you have this many more teenagers and preteens, wait, how many cancers are you preventing? What can I do to make a difference? So it takes people like that. She has now become our corporate vaccine champion and is championing Zostavax for seniors and is championing pneumococcal vaccine for seniors and for adults who warrant that vaccine. So again, I think it's empowerment. It's giving people credit for understanding. It's giving people credit for being able to communicate. And it's looking for those people who will step up to the plate, who would like to be empowered, who would like to make a difference. And I think if you give permission, whether it's a physician or whether it's multiple staff people, you will find those. We have one office, and I'm just going to be totally frank with you, we have one office where the physician doesn't care, couldn't care less. His immunization rates have increased faster than anybody else's in the entire company because his office manager is on fire about this, and his staff is excited to be able to do something to make a difference in the patient's lives, and he doesn't mind. He lets it happen. So again, I think it's empowerment.
That's great. Are there any other questions on the line? Otherwise, we have another one here. Okay, one of the question came, and it relates to what you were just saying now about office staff. It's these electronic order sets that you talked about. And so for a clinic to have electronic order sets, they certainly have to have electronic medical records. But just can you tell us a little bit about how difficult it is to set this up, how costly it is to set this up? And then before I finish the question, just to remind everyone on the call that if you would like to be directly invited to the next Cervical Cancer Free Coalition webinar, you can email us at ccfa@unc.edu. And also, if you want to get other information from Dr. Kassler, as mentioned, we're happy for you to contact us again at ccfa@unc.edu. So Alex, about the electronic order sets.
Absolutely, and thanks. Jen, to follow up on what you said too, I mean, this is a mission for me. This is a passion that I have, and so anyone who wants help with, oh, we'd like to try this, but we're not sure how to do it, I'm really happy to have you reach out to me through the organization, and I will help you any way that I can. So just so you know that as a resource. The order sets were very easy for us. We happen to use Allscripts TouchWorks, and I had a person from our IT department create the follow-up orders, and those are simply follow-up referral. They're under follow-up and referral on our tab. And once you order those items one time associated with health maintenance, they fall into a problem-based order set. So it was literally that easy to build that set. And then once it was built, I was able to actually have our IT people copy it for all of my partners into their order sets so that it would just show up as soon as they clicked on health maintenance and went to their problem-based orders. They were all available. So it took about 5 minutes of IT time, and it took about 5 minutes of my time to build those order sets. And then it was just a matter of each of my partners learning, you know, it's the old dog new trick thing, to remember to click. So pretty simple.
Okay. That's great. And then another question that's been raised is this issue of, you know, as you talked about, your partners in your practice are open to the transparency of revealing data with each other. And I can imagine this is, in some other clinical settings, it may be a more sensitive issue if they're not as used to that. So for group practices that may be less accustomed to sharing, or as you say, this competition, generation, do you have any suggestions to offer of how you can buy them into the process? And is this related to some of the consensus you built in goal setting, or what is your advice here?
So I'm actually really glad you asked that, because I should have said something earlier. So part of why my partners have been very comfortable with becoming transparent, and it wasn't easy at first. It really was not, especially for the people who weren't doing so well. But the fact is that we are going to be transparent sooner than later anyway. And our group has, again, worked hard towards patient-centered medical home and meaningful use and PQRS and WXYZ and you name it. I mean, all of these things are going to be public on the internet within the next couple of years. HEDIS is another one. Whether or not you've met your HEDIS standards, and again, HPV completion is on the HEDIS standards. So when we talk about our quality goals in our organization, we talk about the fact that A, we're responsible to each other for our own business survival. We need to be doing a great job. We need to be able to show publicly that we're doing a great job, and we'd much rather be transparent to one another and help each other and share best practices. Nobody is looking down anybody's noses. I mean, everyone knows this is hard. And for some people, it's harder than others. Some populations are harder to work with than others, and some physicians are more or less comfortable with the various modalities of communication. That's okay. We all know that someone's better at one thing and someone else is better at another, but we really, really decided when, and I'm sort of a mother, so I took on the maternal role in the department and said, look, we really need to work together as a team with all of our rates before they're on the internet, before you can look them up. And I showed them an example of the state of Maine, which is already publishing asthma data, immunization data, and the public has a right to know how their physicians are doing. We should know first, and we should have worked at being the best that we can possibly be before that gets published.
That's really, really helpful. I guess are there any other questions from the audience? Okay, I guess the other question that was raised was you actually said verbally your script, which I thought was really brilliant, because you had the digital coccal, then you had the HPV, then you had the Tdap. So is it that order that you planned, in that order, so HPV kind of just slips in the middle, or?
Absolutely.
Okay, and yeah, and would you be willing maybe to share at some point that script with others? Because I think we've always are debating with how do we make the message, as of course adolescent platform, but have you tried different messages and you ended up with that one, things that didn't work?
Oh gosh, absolutely. And you know what? All of us, the physician lecture was really, really revealing, okay? So all of us used to, okay, well, you need your Tdap for school, and then we'd really like you to do the meningitis at 11 and another dose at 16, because although that's rare, it's really very deadly. And then, oh, by the way, you could do the HPV. That's a sexually transmitted infection. We know your child isn't sexually active now, but they're probably going to become sexually active later. So everybody used to put it last and then talk about it till we were blue in the face, like we were trying to convince somebody. And so the message is, it's not as important, and we're not very comfortable with it, and we need to be defensive. And I think that's because we hadn't gotten our heads around it yet, that this is just another vaccine. And in fact, it's probably the best vaccine that we have to offer. And so we can't present it like an apology. And so now we do the psychological thing that says we're going to sandwich it. We'll preface it with okay, this vaccine, you know what, it's really, really rare, but the death rate is so potentially high that if your child is the one in a couple of thousand that gets meningococcal disease because I didn't make you do it today, I'll never be able to live with myself. So this one you can't walk out with today. My second choice, if you're going to let me do 2 vaccines, which anybody can do 2 vaccines, a 1-year-old does 3 or 4, is the HPV, because that's going to prevent cancer, and I want that finished before your child turns 13. And then you have to have that whoop and cough vaccine for school. I'd love you to do it today if you're tough and you want to just front load and get 3 done. But if you really want to spread them out a little, I'm fine with that. Let's do that the next time you come in for your second HPV. I'm giving equal weight to all 3 vaccines. I'm prioritizing based upon immediacy of potential danger. And I'm leaving families out if they don't want to front load all their vaccines. And this is the tack that all of us have taken in our group. Those of us who have the quote-unquote best practices, the highest rates, have gotten it a little bit more slick than others, but we're all working on that presentation.
Great, thank you so much. I guess that there's one question also from the audience was, when you were doing the physician and staff education, did you bring in an external speaker, or did you count on educating from someone like yourself, an internal champion?
So the physician lecture came from my colleague. Is it okay for me to advertise his name on the webinar, Jen?
Yeah, sure.
Okay. So a lot of you may know Michael Brown. He's a pediatrician who's on faculty over at All Children's in St. Pete, and he teaches for the family medicine residency program at Tampa General, I believe. He and I know each other because we both speak for various manufacturers, and Michael's a very compelling speaker. And to be honest with you, I knew that my group might not receive the message as well from me as they would receive it from someone who wasn't their colleague trying to tell them how to do things. So we brought Michael over. He did the dinner talk. He's a very compelling speaker. He is so smooth with his words and his parental communication. His immunization rates are through the roof, and he's very comfortable with presenting HPV vaccine as the best shot on the market. And, it's his line, well, you don't put your seatbelt on when you're getting onto the freeway. You put your seatbelt on when you're getting, into the car, and you put your bike helmet on before you start pedaling. And that's why we immunize against everything. We don't think you're going to get meningitis tomorrow either. And he's just such a great speaker. The staff programs, on the other hand, were scripted pretty much by me. I kind of decided what I wanted our staff to know, and it wasn't rocket science. We wanted them to know about HPV disease. We wanted them to know about the real truth about the vaccine, what side effects it does cause, what side effects it doesn't cause, what myths are out there, so that when a mom says, oh, we're not going to do that, I read blah, 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 the staff can say, well, actually, that's not really true. What it can cause is this. We'd really like you to talk to the physician. And then we shared with them some of the efficacy data. You guys take care of this many thousand teenage patients in your office. This is how many kids' lives you could save if you immunize. That was internal. That was presented by one of our sales reps from the manufacturer who offered to do lunches, and supported by the office managers and the physicians within the offices, so that the conversation got going amongst the staff. Nothing fancy, just including them in the facts and the discussion instead of leaving them at the sidelines to just draw up the shot and give it.
Well, great. Thank you again, Alex, for joining us today, and for all of the participants who are still on the line. Thank you for all of your participation and your questions. Please reach out and be in touch to us at Cervical Cancer Free Coalition, ccfa@unc.edu. We'd be happy to do follow-up to this webinar and invite you to the upcoming webinar that we'll have in the very near future. And please stay tuned for that, and let's go out and compete to try to increase our rates. Thanks again, Alex.
Thank you.